هتكلم على ال CGM metrics, and let me open the scene by the story of Mariam. Mariam is a 12-year-old girl with type 1 diabetes for 3 years. She has erratic blood glucose with attacks of hypoglycemia. You can see here the curve of the girl. She is on glargine, 120 units a day. She has frequent hyperglycemia with few attacks of hypoglycemia, and you can see the total daily dose, 1 unit per kg per day, and A1C 8.8. We tried to modify the diet, the lifestyle, and increase the glargine 100 and ultra short acting. So the glargine 100 is 22 units a day, and aspart extra 2 units per meal. Now, 3 months later, this is how it looked like. We increased glargine 100 to 22 units a day. Hyperglycemia improved, but there are frequent severe attacks of hypoglycemia. And you can see the A1C went down, but at the expense of having attacks of severe hypoglycemia. And then 3 months later, we shifted her to glargine 320 units a day, which is less than the glargine 100. The hyperglycemia improved without hypoglycemia, and this is a very good point, and the A1C is fine. So you can see here that glargine 300 did the trick, and you can clearly see that we cannot always rely solely on hemoglobin A1C. FDA and EMA expanded the use of glargine 300 for childhood diabetes type 1 and type 2, starting from the age of 6 years and above. So I think you agree that insulin glargine 300 fairly won the game over glargine 100. So this is very well known. Please remember that early implementation of intensive therapy in type 1 diabetes reduces the risk of macro and microvascular complications. And the second generation basal insulin analogues, glargine 300 and insulin degludec 100, offer more stable and prolonged pharmacokinetic and dynamic profiles versus the first generation glargine 100 with less hypoglycemia. And there are limited data comparing glargine 300 and degludec 100 in people with type 1 diabetes, and no randomized controlled trial using CGM-derived time in range as the primary endpoint. And I'm going to share with you a study in this regard. Of course, we all know the danger of hypoglycemia in children and the risk of hypoglycemic brain injury affecting the brain development, ending by functional changes. So it's very important to avoid the occurrence of hypoglycemia in children with type 1 diabetes. And this shows you that when managing children with type 1 diabetes, every step counts. You're leading a child, you're leading a whole family, either to the good pathway or to the very risky management with complication. So I think the question here is how to think right when dealing with a child with type 1 diabetes. If we take a closer look to the life, the daily life of a diabetic child, every day in the diabetic children's life makes them feel different from their peers, which even makes the management more and more difficult and challenging for the diabetologist. And the main challenge is to maintain the balance between glycemic and metabolic control and emotional stability of those children. In fact, we need to maintain health and happiness of those children. CGM is preferred than standard basal glucose measurement in diabetic children. And the problem in blood glucose monitoring is that it misses the highs and the lows. As you can see, sometimes the A1C is fine and you have highs and lows. It does not connect the blood glucose result to the behavior, and it may not meet the accuracy requirement. So indeed, CGM is the preferred way to assess the blood sugar. And CGM monitoring improves metabolic control in children with type 1 diabetes. Indeed, CGM is an effective tool to improve blood glucose control in pediatric diabetes, and it was clearly mentioned in diabetes care that the real-time CGM in conjunction with insulin therapy is a very useful tool to maintain A1C and reduce hypoglycemia. And the metrics derived from CGM over the recent 14 days, including time and range, are recommended to be used in conjunction with A1C. So we cannot just rely solely on hemoglobin A1C, and this was mentioned by ADA Diabetes Care 2021, very recent mentioning. So what are the measuring outcomes? The old hemoglobin A1C or the new time in range? As you see here, the time in range is a new metric to measure glycemic control in diabetic patients. And you can clearly see in this graph, it ranges between 70 to 180 milligrams per deciliter. The time in range refers to the percentage of time that the person spent with the blood sugar in the target range. So we need the blood sugar to stay in the target range as much as possible, between 70 to 180. Also, other definitions include the time below range and the time above range. And here you can see again, the ADA guidelines recently recommend using time in range, time above range, time below range, and glucose variability to assess glycemic control. So it's very important to take a closer look on the CGM metrics and overview the definitions. This is a closer look. You can see here the time in range from 70 to 180 milligrams per deciliter, and above 180 being time above range, below 70, this is the time below range. So what info does CGM offer? Again, the same definitions. We have level 1 hyperglycemia above 180. We have level 2 above 250, and both are time above range. What about the time below range? We have level 1 hypoglycemia below 70, and level 2, which is very dangerous. This is less than 54 milligrams per deciliter. And together, these are the time below range. So we need to define the time in range, which is 70 to 180, the time below range, the time above range, and glucose variability. And this is the very important measure by which we can assess the blood sugar in children with type 1 diabetes. Another important question: what glycemic targets do we need in patients with type 1 diabetes? And these are the definitions proposed by ADA 2021. You can see here, these are the target. Our target is the time in range. The target range between 70 and 180 to be more than 70% of the time, 70% of the day. The high level 1 hyperglycemia, less than 25%. The very high, less than 5%. The low level 1 hypoglycemia, less than 4%. And the very low, less than 1%. These are glycemic targets proposed by ADA 2021. So let me ask you this very simple question. Now, speaking generally, which is more accurate, do you think? Is it the A1C or time in range? Who will vote for the A1C? Thank you very much. No one. Who will vote for the time in range? Yes, thank you, everyone. Indeed, time in range. And this is what was proposed by ADA. Time in range is more than a number. It's not just a number, simply because hemoglobin A1C does not tell you the full story. Also, one metric cannot tell the full story. The time in range can be different at the same A1C. Here you can see 3 examples, example 1, 2, and 3. In the three examples, the A1C is 7. And if you look at the time in range, which is in the green, you can see in the first one, it's 18%. In the second, it's 63%. In the third, it's 100%. And all of them have an A1C of 7. So again, we cannot rely on hemoglobin A1C. It's the time in range again and again. And there are many phases of a 7% A1C. Again, you have three examples here. In the first, the range is 40%, time in range. In the second, it's 70%. In the third, it's 100%. All of them have the same A1C of 7 and a mean blood sugar of 154. So simply, you can have a normal A1C with lots of hypos or lots of hypers. So we need to rely on the time in range and the CGM metrics. Now, comparing A1C and the time in range, is there a difference? Of course, there's a big difference between both. For the A1C, it's a single A1C level. Comparing A1C 3 months apart, it does not capture the hypo and the hyperglycemic events, and this is very important. And it's less likely to capture the acute events that happen with diabetes. It's a chronic condition. It gives you a general overview over 3 months. What about the time in range? It evaluates continuous glucose level. You're seeing a continuous film or story of the child's blood sugar all over the day. It may compare fluctuation in any time, any given time. It captures all variations in glucose, the hypo and the hyper, and it can capture the acute events in the life of a type 1 diabetic. So again and again, we vote for the time in range. So I think you agree that time in range fairly wins the game over hemoglobin A1C nowadays. And the time in range can predict the future risk of diabetes complications. Every 10% increase in the time in range reduces the risk of microalbuminuria by 40% and the retinopathy by 64%. So again, it can predict complications in children with type 1 diabetes. So I think it's time to move on from hemoglobin A1C to the time in range. The time in range goes beyond the A1C, representing the blood glucose. It captures variations, the highs, the lows, the in-range values characterizing life in children with type 1 diabetes. So we need to move on from the A1C to the time in range. Another key CGM metric includes glucose variability, measured by coefficient of variation. And we need that children with type 1 to have a glucose variability less than 36%. This is our target proposed by ADA. And you can see here again, A1C does not accurately reflect glucose variability. You can see here two examples. In the first example, the A1C is 8. In the second example, the A1C is 8 also. But in the first one, there's a very high glucose variability, ups and downs, ups and downs. In the lower one, there is low variability, which is our target. So again, don't rely on A1C to reflect glucose variability. Now, again, you can have a similar A1C, but different glucose variability. You can see here A1C of 7.1 and here A1C of 7.1. What do you think? Which is better? Example, Rami or Sarah? Which is better? The first or the second case? Both of them have an A1C of 7.1. Glucose variability in number 2 is high, ups and down. So the first example is better than the second. And the high glucose variability predisposes to microangiopathy with more glucotoxicity, lipotoxicity, epigenetic changes ending by microangiopathy and complications. So this is a very fast review. I'm going to share the research done, the clinical trial, the time in range using insulin glargine 300 versus insulin degludec 100 in type 1 diabetics. And this is a head-to-head randomized controlled trial. The in-range is the first randomized controlled trial in adults with type 1 diabetes, comparing glargine 300 to degludec 100 with primary endpoint assessed through time in range, as you see. The study design here is a 12-week multi-center randomized active controlled parallel group open label study comparing glargine 300 and insulin degludec at 12 week with primary and secondary endpoint measured at 12 week. And the study population is adults aged 18 to 70 years with type 1 diabetes with an A1C more than 7 and less than 10 and not taking glargine 300 or degludec in the last 30 days. So as you see here, the primary endpoint is a time in range of more than 70, less than 180 at week number 12. The main secondary endpoint, glucose variability at 12 weeks, and then the hierarchical testing procedure. You can see step 1, non-inferiority of glargine 300 compared to insulin degludec 100. This is the primary endpoint. Step number 2, non-inferiority of glargine 300 compared to degludec 100 on the main secondary endpoint. And the last step number 3, demonstrating superiority of glargine 300 over insulin degludec on the primary endpoint. And these are secondary endpoints included in the study. We have glucose variability, change in A1C from baseline at week 12, TBR percent, time above range, time below range, the incidence of hypoglycemia, and the adverse events. All of these were compared. Now, what about the results? You can see here that in those on glargine 300, 165 completed the study and 167 in case of insulin degludec. And regarding the baseline characteristics between the two groups, there was a non-significant difference in the baseline data regarding the age, sex, BMI, time of diagnosis, A1C, age at diagnosis, time since the first intake, and insulin analog treatment. And these are the basal characteristics compared between the two groups regarding diabetes complications. Again, there was a non-significant difference between the two groups. What about the efficacy? You can see here at the primary endpoint, the time in range, there was non-inferiority of glargine 300 versus degludec 100 regarding the time in range. So it was not inferior to insulin degludec. What about the main secondary endpoint? Again, the main secondary endpoint was met. Non-inferiority of glargine 300 versus degludec was demonstrated regarding glucose variability. So it is not inferior. Now, regarding the time in range, there was superiority of glargine 300 versus insulin degludec on the percent TIR was not demonstrated. So it's not superior, but again, it is not inferior. Now, regarding glycemic variability and A1C, hemoglobin A1C change, again, there was a non-significant difference between glargine 300 and insulin degludec. You can see here the A1C is 7.5 and 7.36. They are not different between the two groups. What about the time above range and the time below range? There was a non-significant difference regarding these two parameters regarding descriptive data between the two types of insulin. Now, what about the safety? Regarding hypoglycemia over 24-hour, the incidence and rate of hypoglycemia between the two groups was the same. Regarding nocturnal hypoglycemia, the incidence and the rate of hypoglycemia were similar, although it was not significant, but based on numerical number, the rate of nocturnal hypoglycemia was less in the group of glargine 300. And regarding the diurnal hypoglycemia, again, the incidence between the two groups was similar. And the safety measures and profile observed consistent with glargine 300 and degludec was the same. So even the adverse event did not differ. Regarding the basal insulin dose, the tertiary endpoint, it did not differ. The dose requirement between the two groups, glargine 300 and degludec, was the same. So what are the conclusions from this study? Again, the in-range study is the first randomized controlled trial comparing the second generation basal insulin analog, and this is glargine 300 and degludec 100 in type 1 diabetics using time in range as the primary endpoint. And the primary endpoint was met, non-inferiority for glycemic control regarding time in range between glargine 300 and degludec. And the main secondary endpoint was met as well, non-inferiority of glargine 300 compared to degludec regarding glycemic variability. Also, hypoglycemia and safety profile had similar occurrence of hypoglycemia without any unexpected safety events. At the same time, the incidence of nocturnal hypoglycemia as numerical value was less in glargine 300 compared to insulin degludec. So glargine 300 is non-inferior to insulin degludec in people with type 1 diabetes in terms of glycemic control and time in range and glycemic variability, with no difference in the occurrence of hypoglycemia and safety profile. And the timing of dosing remains to be an important point in controlling type 1 diabetics, with many people administering the basal insulin in the evening. And you can see here that they need a snack to avoid nocturnal hypoglycemia. In case of the time in range study, the basal insulin was administered in a morning dose. So bear in mind that in this trial, it was administered in the morning. Now, let me end by the story of this boy, Ahmed. This is a 7-year-old boy with type 1 diabetes for 1 year. He has a very caring and well-educated family. He develops hyperglycemia at 4 to 10 p.m. post-honeymoon, and this is by regular home blood sugar monitoring. The boy is on 10 units per day at 10 p.m., glargine 100. And you can see here the spike. It gets high. The blood sugar goes up at 4 to 10 p.m. So he has hyperglycemia at 4 to 10 p.m. The total daily dose is 0.8. The A1C is 8.7. Glargine dose, glargine 100 was increased 12 units a day at 10 p.m. and pre-lunch insulin, he didn't benefit from doing this. And then glargine 100, 12 units a day was moved at 1 p.m. We tried shifting the timing. Again, he developed early morning hyperglycemia, and the total daily dose is higher, with A1C that did not differ as well. And glargine 100 was unable to cover the 24 hours, as you've seen. And when we tried to convince the mother to split glargine 100 into 2 doses, she refused. She said she doesn't want to add another prick to the boy. He's already suffering a lot. So the boy was shifted to glargine 300 on 10 units a day at 10 p.m. And look how nicely it worked. The blood glucose improved, the total daily dose is less, and the A1C is better. So glargine 300 was able to cover the 24 hours. It did the trick. And you can see here how it went on. At first, he had 4 to 10 p.m. hyperglycemia. And then when shifting the timing at 1 p.m., he had early morning hyperglycemia. And then when we shifted to glargine 300, the case improved and blood sugar was within the range, the time in range. So I think you agree that insulin glargine 300 did the trick. Shifting the boy did the trick, as you see here. Of course, a lot is ongoing on type 1 diabetes, and we're hoping for a lot to come in the future for the benefit of those children. And basal analogs are an important part of care today and will continue to be in the future. But I think it's very important to balance our choice regarding the type of insulin, the way of glucose monitoring, CGM being preferred to A1C, insulin analog, the second generation being preferred to first generation, and putting all together for the benefit of each child individually. I think this quote applies to what we are saying by Philip McGraw. Sometimes you make the right decision. Sometimes you make the decision right. I think that we as diabetologists and endocrinologists need to make the decision right. by choosing the right type of insulin, the right type of monitoring blood sugar level over 24 hours, the CGM, offering the best for those children and the family. So I think it's always important to make the right decision in order to hit the target properly, which is having a child with blood sugar within the time in range 70% of the time. I will end by this very nice competition. This competition was launched in Ramadan 2 years ago by the Arab Society for Pediatric Endocrinology and Diabetes, whom I'm privileged to be the vice president of this society. We launched a competition and we asked diabetic children all over the Arab countries to draw what they felt. Some of them were very pessimistic and others were optimistic. Sometimes they were so frustrated. As you see, one of them wrote, "Diabetes is not our fault." This is one of the kids. And the other one drew a monster, diabetes as a monster, executing his life. See how they feel, they and the families. But some of them were coping very well with type 1 diabetes. One of them wrote, "Diabetes is my friend." And another one wrote, "Al-insulin hayati." They are convinced how important insulin is. And I think the main thing is motivation. It's not only insulin and diet. We need to motivate those children and the families and to support them psychologically to see their happy faces. Khadija Sayed, 7 سنين from UAE, she wrote, "Alhamdulillah, with these devices, I'm able to control my blood sugar." She's convinced. And Ali Abdullah, 10 years, wrote, أخذ الإنسولين وممارسة الرياضة والأكل الصحي يساعد على خفض مستوى السكر في المعدل الطبيعي. Insulin is their life and diabetes is their long-lasting friend. A lot of photos, a lot of emotions coming out from those lovely children and the families. One of them wrote, "إن مرض السكر رفيق ظريف، إذا احترمته احترمك وإذا تجاهلته دمرك." Here, أخذ الإنسولين مهم لتظبيط مستوى السكر في الدم. Again, this girl, Mariam, 13 سنة من الكويت, drew a seesaw. She's standing at the middle of the seesaw and she's trying to balance her blood sugar, not too low, not too high, in order to live nicely and a lot. And this was the best one who won. I was proud that he was from Egypt. Stephen George Said. He is a 10-year-old boy. He drew this lovely photo. He wrote, "Diabetes is like a friend. If you treat him bad, he will treat you bad. And if you treat him good, he will treat you good." So, وكتب الجملة دي اللي أنا بسرقها منه في كل البرزنتيشنز بتاعة السكر، هو اللي كتبها وأنا خدتها منه. "الإنسولين يصل بأطفال السكر إلى بر الأمان." Thank you very much for your attention. خلصت بدري أهو شوية.
مساء الخير. احنا بنشكر استاذ دكتور سامح على دعوته الكريمه لينا في المؤتمر الناجح ده، وان شاء الله كل عام يكون انجح وانجح ان شاء الله. معانا استاذ دكتوره منى الغمراوي يعني نتكلم على الاير ديفيشنسي نيو انسايتس. اتفضلي حضرتك.
قبل ما نشغل التايمر طبعا ميرسي جدا لتقديم حضرتك، وبشكر الدكتور سامح توفيق على دعوتي للمؤتمر. الحقيقة it's my first time I'm honored to be among all those endocrinologists الحقيقة, and it will be quite tempting to speak about iron deficiency after these delicious talks after such a great presenter Dr. Rasha. I would like to thank all السادة الحضور for keeping up with us لغاية دلوقتي. I'll try to be concise, بس الحقيقة الtopic was supposed to be given more time.